The next expert speaker is of the same species as we do. He is an HPB surgeon. He's a clinical professor at the University of Hong Kong, chief of hepatobiliary and pancreatic surgery in Queen Mary Hospital, Tung Wah Hospital, and University of Hong Kong Shenzhen Hospital. He's an honorary consultant at Queen Mary Hospital and vice president of surgery in ISMIBS, president of the Hong Kong Society of Hepatobiliary and Pancreatic Surgery in 2022. Please welcome Professor Tanto Cheung.
Thank you. Thank you so much. I'm switching from gynecology to HPB surgery, so I mainly focus on liver cancer. So if you know, liver cancer is a big problem in Asia because of hepatitis B infections and also patients with tumor and also with cirrhosis. On the left-hand side, you can see the conventional way of operating in open surgery. We use a Mercedes-Benz incision. So that is a big surgery, a big wound, right? In the past 10 years, we try to do it in a smaller wound, right? Omitting the left side of the incisions. But on the right-hand side, you can see if we use a minimally invasive method, I think we can operate, okay, using a fenestrable incision and take out the wound. So all this minimally invasive surgery, I actually took parts around 10 years ago because before that, we all think liver surgery is impossible to be performed using minimally invasive method. This is in Morioka, Japan. So I'm one of the panel members. So we have discussed the role of minimally invasive surgery. At that time, we think this is a good method for small liver resections, right? And for major liver resections involving resection of more than 3 segments of the liver, probably still is under investigation and has to be done in the high volume center. In 2018, we host the Apple meeting in Hong Kong. Actually, next week, we have another Apple meeting in Hawaii, and I think many of the liver experts will be going there, right? In Queen Mary Hospital, we have a very high standard on liver cancer surgery. We have an aim to achieve 0 hospital mortality, and I think the world standard nowadays still less than 5% hospital mortality, and if you operate in patients with liver cancers. So this is one of the operations we perform now routinely using a laparoscope and using ICG-guided camera. We control the hepatic artery and also the portal vein individually. Okay, and we clamp the inflow of the vessels, and then we can check. You can see that there's a demarcations of right and left side of the liver. We control the portal vein, and we also perform our intraoperative ultrasound to make sure that there is adequate flow to the remaining liver using a CUSA and the bowel duct control with a stapler. And we took out the right hepatic vein with a stapler. And this 10-meter tumor can be removed through a fenestrable incision. So nowadays, we also use the robot, okay, to operate. So in Queen Mary Hospital, we also use the Da Vinci Xi camera, the robot system. And we also have a system can be using student console, or we can use a 3 arm altogether at the same time. This is one of the operations with left hepatectomy. So again, just like minimally invasive, we can also use the robot to operate in the major liver resections. So this is control of the inflow with a pingo maneuver, right? So we can also control the artery and portal vein individually, just like in open manner and also in minimally invasive laparoscope manner. So we cut the vessels. You can see there's a demarcation because there's no blood flow to the left side of the liver. And we use the scissors You can see after the inflow control, there is virtually no blood or very little blood. And using laparoscopic or robotic surgery, actually we have a pneumoperitoneum, and actually that compress on the vessels, and that it will help us in the decrease in the blood loss, right? So all the way through, you can see with exposure of the hepatic ring, right? And there was a very little blood loss, all right? And we're using, this is using the harmonic scalpel, just like CUSA, right? Okay, we are using. So after 50 minutes, we have a 5 minutes break, and then we can continue. So this is after 2 Pringle maneuver. You have a complete split, okay, of the left lobe of the liver, and you can control the bile duct, and we use 2 hemolog to divide the bile duct and then stapler the left hepatic ring, okay. So this is the last bit. We take out the whole left lobe of the liver. It's around 3 hours work, okay, skin to skin, and this tumor, together with the left lobe of the liver, is delivered through a fan and steel incision, okay. All right. So this is ICG guided. A very good throw to the right side of the liver. Good. So robot versus laparoscopic liver resection, I think in most of the center with a high volume have concluded that robot is actually associated with less learning curve time, right? Probably laparoscopic procedure has a shorter operation time because you don't need to dock the robot. But with time improvement, I think this time of a preparation time will be decreasing, so there will be less difference. There was a transfusion rate and blood loss is similar between robotic surgery and also laparoscopic surgery. Conversion rate, okay, is similar. It's around 6 to 10%, depending on different centers. And we can achieve R0 resections in most of the cases. And there's no difference between the complication rate between the robotic system and also the laparoscopic system. But we can also understand different part of liver has a different difficulty score. It will be easier to resect tumor in the inferior segment and also lateral segment of the liver, right? Segment 8, segment 7, superior portion of liver is more difficult to be resected. But again, this is not 10 years ago, and actually we have participated this international research, and also shows that minimally invasive surgery can be done, okay, in different part of the liver and even in the major liver resection. So in 2018, we have concluded that the use of a 3D system, augmented system, and also ICG system will be a standard of practice. And nowadays, actually, every system is incorporated of these 3 additional actions. So this is last year, and we also presented a paper using robotic and also laparoscopic hepatectomy, right, for a very big tumor, right? So this is a 15-centimeter tumor.
This is a very big tumor
on the right
over the
side,
right
okay.
side of the liver, occupying around 15 centimeter in diameter. The left side of the liver is normal. With a lymph node enlargement, we also perform higher lymph node dissections. For very distorted liver, I think sometimes it could be very difficult because of the distorted anatomy. So after cholecystectomy, we have exposed the liver hilum, but it's quite different from the normal anatomy that we usually encounter. So we control, okay, the right posterior pedicle and also clamp the right anterior pedicle. We cannot totally circle the right anterior pedicle. That's why we put on bulldog clamp, okay. And after the dissections, okay, we have more space. We can control the right anterior pedicle. We can control it by hemolog, and also we divide the bile duct with the stapler. So using ICG camera, the advantage is that for this very distorted anatomy, okay, sometimes the bile duct will be distorted. We don't want to control a staple off the left hepatic duct. That's why the application of ICG camera become handy. Okay, so that's closest margin is actually on the IVC. So there's a hole in the bile duct. We suture it back, and we have used ICG camera make sure that the left duct is patent.
So this is a study, international study, take part in more than 42 centers, actually including all tumor more than 10 centimeter in the size. Actually, we found that robotic system has been used in 219 patients. And I think the result is quite similar between both group, but there's none hospital mortality in the robotic group. So Whipple, so this is a Whipple operation. Probably we'll skip that, right? Neoadjuvant therapy now become a very hot topic because in 2024 now we have 9 different drugs that is effective against hepatocellular carcinoma. Comparing to 2006, we only have one sorafenib, that is a one targeted therapy. Now we have different combinations. So this is during the era of COVID, because the waiting time has been quite long. The patient has to wait for surgery. We give a PD-1 before surgery, and when they take a biopsy, okay, and then we operate on the patients. We have included 20 patients and giving them 3 cycles of nivolumab. And then we have actually 20 patients all undergone hepatectomy. We exclude 1 patient because of intention to treat analysis, because that patient has a tumor progression. We add on 2 more CTLA-4 and also 1 target therapy to treat the patient, and then actually that tumor regress and we operate on this patient, right? Tumor size median is 13 centimeter. Largest one is 16 centimeter. We found that even with 3 doses of PD-1 inhibitor immunotherapy, the response rate is quite satisfactory in 50% of the HPV infected patients. So we have come to this that we actually found that for patient who has good pathological response, actually they have less recurrence. So this is one patient on the left-hand side. You can see a 5.9 centimeter tumor after 3 cycles of drugs, and that is shrinked to 4.6 centimeter. And on pathology analysis, that is 100% necrosis. So this is another patient, a 15.5 centimeter tumor. After 3 cycles, you can see size did not shrink a lot, but you can see there is a significant necrosis and loss of hypervascularity, okay, on the right-hand side. And I perform a central resection on this. Very specifically, patient responding to immunotherapy, they have a characteristic of hemorrhagic necrosis that is unique, okay, are not seen in other part of the response, like in the VEGF inhibitor. So for patient who is responding to the drugs, actually, they have less recurrence when comparing to patient who are not responding. But we understand that not every patient can receive surgery because of presence of liver cirrhosis. And many patients in liver cirrhosis, they also have ascites. And HIFU actually take advantage of this characteristic. Patient with ascites is a good medium for absorption of ultrasound energy, right? So for the focal point on microscope, you can see coagulative necrosis. For the unaffected area, you can see on the microscope, there is very little damage to the cell. So this is one of our patients. Actually, we have reported this patient. This is first in the world bridging therapy before liver transplantations. This is a patient with a tumor on the segment 8 of the liver with ascites. We cannot perform radio frequency ablation, right? So we use HIFU, and after 1 section, you can see a complete necrosis. We have published this paper in 2012 and shows that in the explant pathology, actually there is 100% necrosis of the tumor. The patient have a liver transplant because of the liver cirrhosis and ascites. Further on, we have done more patients, and actually, it is an effective way in severe cirrhosis patients, and can prevent patients from dropping out from the liver transplant waiting list. Last week, actually, we have installations of a JC300 model in Queen Mary Hospital. We have replaced our old system, all right? And I think in conclusion of the last 10 years experience we have done, we found that when comparing to radiofrequency ablations, so HIFU is non-invasive, there is no needle track, there's no it, and it is favorable in patients with ascites. And if you operate, all right, on the patient after HIFU treatment, we do not find any adhesions when comparing to radiofrequency ablation or microwave ablations. So these are the advantage. We have also compared the tolerance and between radiofrequency ablation, microwave ablation, and HIFU. For overall complication rate, okay, of RFA is around 14.2%, right? For HIFU treatment, okay, it's around 56% minor complications, but for major complication, I think it's less than 6%. All right. For microwave ablations, right, comparing the three modality, I think this three modality has a different role. I think the most tolerable treatment option probably at this moment is still high intensity focused ultrasound because of its nature, right? The JC300 model has increased an advantage of giving a camera, okay, underwater camera, so that you can prevent skin injury. So I think that is the most important complication rate when we are treating patients with liver cancer, because there's a rip, okay, in between the ultrasound energy and also the liver tumor. So that increase the chance of skin injury when comparing to fibroid treatment, I think. So I think the and also the minimally invasive treatment is an important area to study, particularly with increasing importance of systemic therapy that is effective. So we will have more and more patients downstage, and then we can treat patients with liver cancer with all sorts of minimally invasive and non-invasive method. Thank you very much for your attention.